Welcome to Physio Discussed. What are the most challenging injuries facing runners? What is a physio's role in the management of bone stress injuries? And what is the role of footwear in injury management? We are joined by two brilliant minds today. So welcome to you both, Brad and Rich.
Thank you, Sarah. It's a pleasure to be here. Thanks for the opportunity.
Yeah, thank you, Sarah. It's awesome and great to be here with Brad and with you as well.
And all the way from the US as well, Rich. Thanks for staying late, and Brad, thanks for getting up early.
Absolutely. Wouldn't miss this one.
Yeah, superb. Happy to be here.
Well, we've got plenty to get through today. So let's dive right into the topic of managing running injuries. So what are the most challenging injuries to manage in the runner? Brad, I might throw it to you first.
The most challenging injuries to manage in the runner, I find, can be things like proximal hamstring tendinopathy, which can tend to clinically, I find, have a persistence. Patellofemoral pain, we're probably all well versed in the fact that there is a high ongoing sequelae of patellofemoral pain, recurrence rates are high. And then I think thirdly, bone stress injury management might seem relatively simplistic at times, but I think when done well and we consider all the risk factors, the multifactorial etiology, I find bone stress injuries are extremely challenging to manage well.
Yeah, I was just funny. I was thinking those exact ones. I think the proximal hamstring tendinopathy can be really tricky to treat. And it seems like of the tendinopathies, that's probably the one that tends to linger the most, I think. Seems to be a little bit problematic. Patellofemoral pain, I 100% agree with that. I mean, it's the most common running related injury, so you think we would be really good at treating that injury, but it seems like everybody presents a little bit differently. And I think that return to run process can be a little bit challenging. And then bone stress injuries, I would say, I think the first time bone stress injury is not terribly challenging to work with for a lot of these. But I think the high risk, the runner with a repeat bone stress injury may not necessarily be at the same anatomical site, but the runner who's had multiple bone stress injuries typically has multiple risk factors, and those typically are quite challenging to deal with, I think.
Absolutely. What are your thoughts on what makes the proximal hamstring tendinopathy linger for so long and such a challenge to treat?
Sarah, I think the population I see largely can be triathletes, for example. So you've got the combined loads of running with the high tensile compressive loads that anatomical structure can be subject to. And then you've also got, in many cases, many hours of time spent, for example, on a bike. It might be a road bike or it might be a time trial bike. And I think that certainly can contribute in a triathlete's presentation to some persistence. But then outside of that, in day-to-day, in the runner, the running athlete alone, I think it's just a highly loaded area. People sit for much of the day. There's compression there. And beyond that, I really don't know. But, it's certainly something that I'm very clear with patients on, is that this might take some time, but, ultimately we can get there with it. We will get there with it. We've got to persist and understand it and work towards a resolution.
Yeah, absolutely. And I think, as you say, our day-to-day lives are involve so much sitting, and car seats are really designed to hug everyone and all of those factors. What sorts of timeframes do you typically give to your athletes, or is it more around parameters of management?
Rich, I'll throw to you for that one, just for your opinion on that as well.
Yeah, that's a tough one. I think Brad and I see a little bit of a different runner. I see a lot of trail runners, and so I think the same thing. I think that these loads are really challenging to manage. We're with them, they don't necessarily do a lot of cycling, but they do a lot of uphill running and then also a lot of downhill running. And I think that makes it quite challenging. Of course, that's the sport that's the activity that they want to get back to. So I think that can be very challenging. I think the other part too is, like all injuries, the longer you've had it, the the longer it's going to take to recover from it. I think this is one of those injuries that a lot of people try to self-manage for a while, and I don't know, runners, they have some sort of pain, they like to stretch it. And so we know stretching stretching your hamstrings is not a great idea when it comes to proximal hamstring tendinopathy, just because of the compressive forces. And I think the other part too, as Brad mentioned, sitting so much. I think most tendinopathies, when you look at the research, even kind of general tendinopathies, let's say like a run-of-the-mill, like mid-substance Achilles tendinopathy, I think you're looking at a good 12 weeks for recovery for that. I think probably these proximal hamstring tendinopathies, I would say, I don't know, it's not unusual for some athletes to take 6 months or so to really get on the other side of it. And I think, again, that also is really kind of can be preloaded because if they've been dealing with this injury for a long period of time. And I also think that, the type of running that they're looking to get back to, if it's someone who's, kind of doing like some weekend runs or something like that, I think that's one thing. But, the level of athlete that Brad works with, and then the terrain demands of the runners that I work with, I think those can be much more challenging. So I think you should stretch that out a little bit longer for those athletes.
Could I ask Sarah, Rich, the demands of that, as in Rich, the faster running, the higher intensity running, the greater hip flexion? Is that what you're referring to there?
Yeah, exactly. The greater hip flexion. I think that like the longer stride length, because it's really driving that. The hamstring forces are quite a bit more, because the hamstrings are quite active. I think a lot of times people think of hamstrings as being very active during, like, I don't know, push off, like when you're, during like doing like almost like a hamstring curl, but that's not really the case. Hamstring forces are the greatest at terminal swing, and during that initial loading period, that's when that hamstring is, you're asking it to elongate at the hip and also your knee, and so forces tend to be the greatest then. And so the faster you run, particularly if you're running with any sort of grade, I think that's when those forces end up being the greatest. And then, of course, at the same time, you're also adding like this compressive component around the ischial tuberosity. So that kind of is a real recipe for really, really high loads. I think the other part of it too, like let's go back to Achilles tendinopathy. I think you can really use footwear quite a bit to modify loads there in that region, and you just don't have that benefit up at the hip. I mean, there's some other options that you can do from a running biomechanical, like from a gait retrain standpoint, but it's not as easy as just like, okay, let's put some heel lifts in this runner or switch to a different shoe design to modify those loads.
That's a fantastic point. And it sounds like for both of you, the conversations around expectations, around what pain will do and what function will do, and education will be crucial.
I think it's critical from the get-go. As a junior clinician, Sarah, I think I inherited a greater amount of burden for carrying people's injuries than I needed to, and it's quite crippling. So I like to get really clear early that, look, this is not a quick fix. This is a totally unsexy process. But if we put the right things in place from a load management point of view, an exercise therapy progressive point of view, the patient should feel a sense of momentum with their recovery because they're noticing changes in signs and symptoms. They may have flares, but I think it's really important to be clear with the patients. This isn't a quick fix, and give them tools that can help them understand the process. Whether that's a recording with an Ebony Rio on tendon rehab or something. Like, please, let's get you up to speed on how this be.
I think that's a fantastic point, particularly for younger clinicians. It's this shared responsibility and empowering with education. That's a really great point. Rich, going back a little bit, you mentioned we have a really high frequency of patellofemoral pain, and that you perhaps don't think we manage it as well as what we could. Where do you think we fall down in the way of that?
Ooh, yeah, that's a great question. I think part of it. Well, I think it depends on the runner, but I think one of the biggest issues is we often think that I think people often think this is a self-limiting condition, something that has a good natural history that's just going to resolve on its own. And you see that, at least in the United States, you see a lot with adolescent runners, particularly female adolescent runners. And we know that about 1 out of 3 adolescent runners will experience patellofemoral pain. particularly female, and they often will go see their general practitioner, and the general practitioners will say like, "Hey, this is just you're gonna grow out of this, and it'll go away." But we know that the incidence of patellofemoral pain ends up being about the same for adults. So if you've had patellofemoral pain as a teenager, you're going to most likely have it as an adult as well. And we know that one of the strongest predictors of recovery, again, is how long you've had it. So if you've had patellofemoral pain less than 3 months, we know that you have a much greater chance of recovery from that injury than if you've had it for more, longer than that, say 18 months or something like that. So it's really important that when an athlete does experience patellofemoral pain, that they get in and see someone who knows what they're doing as far as from a treatment standpoint. But I think also there's some competing diagnosis that can be tough to rule out. And so I think that having someone coming in just because they have anterior knee pain, making sure that it's truly patellofemoral pain, and there are a lot of associated injuries that are in that area. So infrapatellar fat pad impingement, for instance, is a really common one that seems to be missed quite a bit. I think in the adolescent athlete, I think some of these apophysitis type injuries, so Sending Larsen-Johansson syndrome, Osgood-Schlatter's, I think those are going to be some really important injuries to rule out as well. Patellar tendinopathy, and then also iliotibial band pain as well. So I think like having a really good workup for your athlete and making sure that you're ruling out these competing diagnoses. And unfortunately, there's no single good test to rule in patellofemoral pain. So you have to do this diagnosis of exclusion to exclude other issues, and then go from there.
Fantastic answer. Brad, do you have anything to add on that?
I probably do professionally and personally. I've been a lifelong patellofemoral pain sufferer. I was one of those adolescent athletes, junior triathlete that ran into kneecap or anterior knee pain, patellofemoral pain early in my running days, Sarah. And I'm 43, and I've lived most of my running life managing patellofemoral pain, which is now probably more patellofemoral arthropathy / osteoarthritis. And it's had a huge effect on me. So I really empathize with this cohort. And like Rich said, there's this high, prevalence of it in the running community, particularly adolescent females. I think 1 in 2 athletes that have it as adolescents, it's been cited in the literature, can expect to have it throughout their adulthood. So this, sometimes I think as an industry, we can be overly simplistic with our approach to this. Yet for me, it's one of those injuries that we identified early. I really try and pull out everything we can from an evidence-based rehabilitation point of view to help the athlete tick the right boxes. And I know Brad Neal did his PhD in this and has done some amazing work. And I know that's been cited in Physio Network archives in the past, but, I like to bring in, where appropriate, the podiatrist. There's evidence for foot orthoses having an effect. Obviously, exercise therapy, load management. I actually use a lemonade in the room from Rich Willie about the demands of running uphill and downhill, just to educate the runner. I think education, as always, is so key. And once again, an understanding that this might not be a quick fix. This might take time and work and owned responsibility from the athlete.
Mm-hmm. Yeah, I think there's some other contributing things there too that can make it really tough. And that's like, so if we look at someone who has not run before and they start running, we know that Achilles tendon forces double between when we go from a walk to a run. And hip contact force is the same thing. They also double there too. And so, that makes, for instance, like from a rehab standpoint, as far as your return to running program should incorporate a lot of walking. You should be, walking for 30, 35 minutes before you start doing one of those. The patellofemoral joint is a little bit different. We see that those forces go up almost 5 times greater from walking. So we see a much larger jump when we begin a running program. And so because of that, as soon as you start taking that first step of running, you are placing this patellofemoral joint under much greater loads. And the reason for that is because we go into so much more knee flexion when we run. Our hip kinematics do increase, our ankle kinematics do, but nowhere near to the degree that we see with running. During running, we hit about 45 degrees of peak knee flexion. During walking, it's only about 15, maybe 20 degrees. So that's a really big increase. And so because of that, a lot of athletes will do this kind of start-stop thing. They'll like, okay, I've got patellofemoral pain. I'm going to just take some time off and I'm going to start back up again. And that might work for some other injuries if you catch them early enough. But for patellofemoral pain, you kind of get into this kind of vicious cycle of like injury, rest, deload, lose capacity, and then go again. And before you know it, you got this person who, is having trouble sitting for a long period of time, going downstairs without pain. And then it becomes this thing where you've got this something wrong with your knee and you don't really know what it is. And it's starting to take over a lot of other aspects of your life than just running. And I don't know. And then a lot of times people end up getting imaging done. And we know imaging is not particularly helpful for diagnosing this injury and telling someone how long it's going to take them to get, to get over it. The MRI might pick up other issues that are going on, and then the runner can get very fixated on that as well. So I think the education component, as Brad was talking about, is just so critical. It's like, look, it's really important that we have a very slow and gradual return. Don't get too worried about any sort of pathologies that you might think you have going on in your knee. This is just really just a relative overload injury, and we need to improve the capacity of your knee and your overall system so we can have a nice kind of seamless return to running.
So I'm detecting a trend of educate expectation setting. And I think the biomechanics and hearing the evidence and the research on the biomechanics, it makes sense when it's explained. And I think we do need to get really good at actually translating that evidence across to our patients as well. You've both mentioned footwear. So the next question that I have is, what are your thoughts on what the role is of footwear in the prevention and management of running-related injuries?
Sarah, I'm going to throw to Rich for this one straight out of the gate.
Yeah, I would say I'm quite agnostic about footwear. I think a lot of times, I don't know why. I think, for instance, I think Born to Run, for instance, that book that came out in, I think 2010, I think suddenly there was almost like a value system that was applied to running shoes or footwear. And I think it's worth now taking a step back and looking at the evidence. And I think we now know that it's probably not such this cause of running related injuries that we used to think it is. So I think from a prospective like evidence standpoint, does footwear cause running injuries? I would say that it's important to look at things in a causal framework where it's not just a shoe, there's a runner attached to the shoe. And there's terrain that runner is running through. They've got past injury history and all these different things that we need to be considering when we're trying to decide why a runner has had an injury or has experienced an injury. Now, with that said, shoes can be incredibly helpful when it comes to managing loads when someone has an injury. So we need to make sure that we're differentiating between treatment and prevention of injuries. It's very hard to prevent injuries, but we can really use footwear and foot orthoses and shoe modifications to manage loads so we can help this runner kind of get over that initial hump and get them back to running. I think a good rule of thumb is the closer you get to the ground from an injury standpoint, the more likely we have a greater capacity of being able to use shoes. So for instance, foot and ankle injuries, I think using different shoe designs, foot orthoses can be incredibly helpful. Up at the hip, probably not as helpful. And there are many other things we can probably be doing up there rather than just changing shoes.
And Brad, what are your thoughts on that one?
I think what Rich just referenced there, Sarah, is a great distinction about the role of footwear from a preventative point of view, which is tenuous at best as per most interventions we have in physiotherapy for preventing running-related injuries, as opposed to managing load. I think there's a lot of noise around this topic, and clinically, I find I take a fairly simplistic view on footwear where I consider it as an overall factor in an athlete's presentation when they present with a running related injury. And then depending on the condition, we might contemplate using footwear as a tool, a rehab tool. So whether that's simplistically a runner with anterior knee pain, patellofemoral pain that runs in a lower drop shoe, or someone with hindfoot pathology, Achilles tendinopathy, calf strain history that might run in a higher drop shoe, for example. We know, as Rich teaches on, that if we reduce plantar flexor loads, say in a runner that has tibial bone pathology with a rocker bottom shoe, so just different ways to look at the situation simply, and as Rich referenced there, consider whether there's an opportunity to potentially moderate workload at a certain part of the kinetic chain through shoe interventions.
So what I'm hearing is basically using it as a potential contributing factor rather than as the keystone for any treatments.
Yeah, I think many runners place an overemphasis on the role that their footwear has played in their presentation, and that's understandable. I think it's key to educate them that look, this may have contributed, but realistically, there's this glaring elephant in the room called your running workload, or in your bone stress injury patients, perhaps the energy availability. So putting it into perspective. But then I also think at the pointy end of performance, where the margins are less, footwear can play a disproportionately greater role. For example, one of the triathlon Olympic medalists from this last Olympic Games went off and raced some short course racing after the Olympic Games on some cobblestones in his Vaporflies. And that was enough to take him from having no prior concerns to all of a sudden some peroneal tendinopathy, because he's running on cobbles at 240, 250 pace, and that was enough to put him into a state of reactive peroneal tendinopathy there. So I think that's also worth considering, that the more pointy end of performance, the bigger role footwear may play in the onset of an injury. Would you agree, Rich?
Yeah, 100%. I think with all things, there's like any sort of rapid change in workload, I think makes a big difference. And I think shoes or running surfaces, is part of that too. So I think if that runner maybe had been running on uneven surfaces, like what you described, like cobbles and like a regular running shoe, and then slowly started transitioning over to running in these Vaporflies, probably would have been fine. But you're talking about something much different. You're talking about running at very, very high speeds, very suddenly doing it. I mean, it's a big spike in workload for those peroneals, for instance. And it's funny you mentioned that, because I have seen people get that same injury, some sort of like tenosynovitis or a tendinopathy of the peroneals or posterior tib, running in these like high stack Vaporfly or super shoe type designs. And it usually involves exactly what you're describing, is like suddenly running in those shoes or running on a new surface on them, and the stack height is pretty high. So you've got a higher moment arm there, if you will, between your foot and the ground. And so it does introduce some extra instability. So you're relying more on the stabilizing muscles of the foot and ankle. And so it's not surprising we see some increase in relative overload of those muscles.
Can I just ask, for those that are not familiar with stack height of shoes, do you mind outlining the difference between a high stack shoe and a low stack shoe and a rocker bottom shoe for the listeners, please, Rich?
Yeah, sure. So, I mean, I think one easy way to do it is start with like a minimalist shoe. So, a minimalist shoe is a shoe that's pretty close to the ground. Doesn't have probably a lot of motion control type features in it. So, it certainly doesn't have things like a carbon plate, or for like a trail shoe, it's probably not going to have like a polyethylene or polyurethane like rock plate inside it that's going to shield the foot from like rocks or something like that. So that's a minimal shoe. So pretty low, just a couple of millimeters when it comes to like that overall height. Then you get to like a, I don't know, like a mid drop shoe. What that means, a drop means the difference in heel height to forefoot height. So usually like a mid drop shoe, for instance, might be, I don't know, like a 5 to 7 millimeter heel to toe drop. A zero drop shoe is just like it sounds, like there's no drop from the heel to the toe. And a high drop shoe is going to be 10 to maybe 13 millimeters of drop. And then a high stack shoe is going to be, you can still have a high drop, but you're basically just going to elevate everything up higher off the ground. And so you've got more cushioning there as well. Now, when you do that, that introduces, it really increases the stiffness of the shoe. And so because of that, you'll see in these high stack shoes, like a Hoka is a great example of that, they will often incorporate some sort of a rocker sole design to it. So it basically makes up for that increase in kind of longitudinal stiffness that you're going to see with a higher stack shoe. And then going from there, you start to see some of these like technologically advanced racing shoes. So like the Vaporfly is what Brad mentioned, and pretty much every shoe company now has some version of that. And that shoe is going to have a different type of foam. That foam stores more energy and returns it, so that energy return is a little bit better. Most of these shoes, if not all of them, have some sort of like carbon plate inside it as well, and they will, because that carbon plate, it's a very stiff-soled shoe, they will incorporate a rocker into that as well. And you see rockers too in like other designs. You see them in running shoes, you see them in trail shoes now too, that even with and without this carbon plate. And that rocker sole is really pretty nice because when we toe off, we typically push off of our metatarsal heads. And that rocker sole moves that forefoot rocker back a little bit closer to the ankle. And because of that, it reduces the demand on our plantar flexors and some of our ankle musculature. And it can be a really, really nice design. So you're reducing those plantar flexor forces. But of course, those loads go somewhere, and they typically go up to the knee. And so, you're just not really choosing. You're not, of course, those loads or demands are not evaporating into thin air. They have to go somewhere. So we typically see a little bit higher patellofemoral joint loads when you have a rocker soled shoe. It's always worth keeping in mind. So, but with that said, with a patient that has a foot and ankle injury, I think for most of those, I really like using a rocker soled shoe. It really reduces a lot of those forces. As the plantar flexor forces go, so do forces in the foot and forces in our plantar fascia, Achilles tendon, metatarsals, and so forth. We don't want to use that kind of rocker sole design for is that perhaps like a calcaneal injury. So like a calcaneal bone stress injury, fat pad injury to the calcaneus, for instance, because it shifts that center of pressure further backward. But otherwise, it's a really nice design. For a long time, there weren't any rocker soled shoes on the market. And now there's a whole bunch of them. Like Asics has a really nice line. We use like North Face has a really nice trail shoe, the Vective series. It's a trail shoe, but it runs quite nice on the road. And so I like that shoe a lot because it's got a little bit of a plate in it, this polyethylene rock plate, and that seems to be really nice for runners recovering from a metatarsal bone stress injury to help them get back to running.
That's a fantastic summary. Thank you. Brad, do you have anything to add to that one?
I was actually going to ask Rich, if I may, Sarah. Several years ago, Rich, in Melbourne running course, you put up a slide about super shoes, and there's conflicted evidence on whether they increase or decrease work at the foot ankle. Like, where's the literature at the moment?
Yeah, well, yeah, that's a great question. So and these shoes are really kind of very interesting because a lot of them are proprietary technology, and so Nike or Asics or Brooks or whatever, they don't release this data. So you don't really know these biomechanical loads, but what we do know is that there's a performance advantage that comes with these shoes. So I think that the performance advantage has been studied really quite well, but now we're starting to understand like some of these biomechanical implications of wearing these shoes. And so where that advantage is coming from, it's really even hard to tell. A lot of times, like before we used to think it was this carbon plate. It's kind of like springy, and so a lot of times people thought that they were just kind of like using this almost like as a springboard kind of thing. But been some really nice studies that have tested these shoes with and without that carbon plate, and it seems like that energy return is still there. So it's probably the foam that is our biggest contributing factor when it comes to like improving metabolic efficiency of running. When it comes to like the biomechanics, though, this rocker soled shoe or sole tends to shift loads away from the foot and ankle. And so we see lower tibial bone forces, we see lower Achilles tendon forces in these shoe designs. And that can be really helpful. You can really be really helpful again for helping a runner get back to, with a certain like foot and ankle injury. But again, those loads are probably going up to the knee, and that's what the evidence is starting to say. So I think there's, with that said, there's been some papers that have come out, or at least there's been one paper that was in British Journal of Sports Medicine. It was a kind of almost like this case series that talked about a seemingly higher incidence of navicular bone stress injuries running in these technologically advanced running shoes. And I'm going to be interested, Brad, to hear your take on it. I know that was one of the things that we talked about at that course, but I don't know. I think my perspective on it is that, yeah, it does seem like, at least anecdotally, we're seeing maybe some different bone stress injury kind of presentations in the athlete who wears this shoe. And I think that's something worth chatting about. I've got my own ideas, but Brad, I'd be interested to hear what you see and what you think.
Yeah, I think it's it's always hard to link cause and effect with a presenting athlete, but and then it's the population bias. I mean, working a lot in triathlon, there's the energy availability considerations, and as you teach, Rich, the more proximal a bone stress injury presents, the greater likelihood energy deficits have potentially played a part in that injury's presentation. So it's hard to weed all that out in isolation, but I do see a lot of proximal bone stress injuries in the running population, and most runners that are pushing for performance have transitioned to spending a considerable amount of time, I find, in carbon plated shoes. And it's, for their intensity sessions, they're running in them. Oftentimes they want to run in them for the long runs. So I think the overall distribution of minutes in these shoes has gone up, but then as to the correlation to things like, say, proximal bone stress injuries because of these shoes, it's very hard, I find, to weed apart.
Yeah, I would agree. I think I mean, as I like to say, there's a runner attached to the shoe, so and that runner has risk factors. And as you mentioned that, I totally agree with what you were just saying. It's like the runner who's looking for a 3 to 4% gain in their out of their shoes is probably looking for maybe a 1 or 2 or 3% gain from elsewhere in their overall like performance. It might be diet, might be they might be less likely to skip workouts, might be, doing more speed work or something like that. But one of the things that you see in the literature too is that running in these shoes seems to reduce muscle soreness. And so, I don't know, muscle soreness is kind of nice. It gives you some feedback like on how you're adapting to loads. And so if you're not getting as much muscle soreness from your workouts, you can maybe stack more high intensity work sessions into your normal training week. And so I think that the fact that we see two major trends when it comes to, at least this is what we see here, is we see much greater use of these technologically advanced running shoes, and we see a much greater use of double threshold workouts in normal training programs. And so what I mean by double threshold is that they're doing a threshold workout 2 times in the same day. So like on a Thursday, for instance, they might do a track workout in the morning and then like some more threshold work in the afternoon. And these shoes allow you to do that because you don't get as much muscle soreness. But of course, you're also running faster too. I mean, as we know, as you run faster, the likelihood of bone damage goes up as well. So you put those things together. We also know too that if you're training very hard, you might not get as much muscle soreness. But I don't know about you all, but for me, when I do a hard workout, I sometimes it's almost like this as appetite suppressant. So I might have a harder time consuming calories between those workouts. I might maybe restrict my calories going into this high intensity workout because I'm worried about having some sort of GI distress. And then because you're running at a higher intensity, the overall metabolic demand of that day goes up quite a bit. And so I do think there's probably a bit of a role, but again, I think it's like you have to think about it in this causal model where there's lots of factors going on here, and I think it all those things kind of roll up into the eventual like development of a bone stress injury, and so I think that's why we see more. So this is one of the things that I don't know if you're seeing this, Brad, but we're seeing more kind of sacral BSIs, for instance, and femoral neck BSIs in runners who are wearing these shoes. And I think it's because those injuries are trabecular bone sites. And trabecular bone requires a lot more energy. And so that's why we associate these proximal bone sites with a greater likelihood that the athlete is experiencing low energy availability. And so you put all those things together, you're like, okay, now that makes a little bit more sense than saying, if you run in these shoes, they're going to give you a femoral neck BSI. I mean, I think that it's important to just think about all those different factors together. And with that said, we're starting to see in certain teams that suddenly they've got this proximal bone stress injury issue, and you're like, well, like what's going on here? And then you kind of like reverse engineer what's happening there, and a lot of times it might be that they started doing double threshold workouts, and then they've done some other things too that from a culture standpoint that I think matter a lot, that I think we don't probably consider often when we're treating this individual runner until we start seeing a lot of runners from the same team with the same injuries.
It's sounding like our role as clinicians is certainly in getting really good at zooming out and then zooming in on each of those contributing factors to build the overall picture rather than focusing on just the footwear. But as you say, those are fantastic points around actually educating what the footwear might allow and therefore may create in the way of bone stress injuries. You both mentioned, and you've both explored it a little bit, the energy deficiency in sports. How do you think clinicians can best screen for RED-S or relative energy deficiency in sports?
Clinically, Sarah, I think firstly, we need to be having a high index of suspicion that this could be part of a presenting athlete runner's presentation. So I think starting there, having a high index of suspicion, having it on our radar. But then in terms of, I find my clinical work, we talk about these secondary indicators, and Rich does a lot of teaching on this. I have them built into our pro formas for the clinic, just to make sure we don't skip over them. But things like, not finishing workouts, poor performance, a decline, obviously for the female athlete, menstrual cycle changes, amenorrhea, loss of 3 periods in a row or irregular menstruation, erectile function for the male athlete. And these things can sometimes be seemingly tricky to bring up in consultation, but I think when we realize the overall impact, if we don't screen for this and ask these good questions, it can be quite catastrophic for the athlete. Get past that awkwardness. So erectile function for the male athlete, body weight changes, diet changes, prior history of bone, gastrointestinal upsets, low iron on blood work, for example. These can be some of the secondary indicators that I like to screen for just as part of a subjective examination, Sarah, of a presenting runner. No matter what the injury, whether it's soft tissue or bone, I like to ask these questions, and I'll throw to Rich for his further input on this.
Thanks, Brad.
Yeah, I think you bring up a good point, and that we often just say we're only going to screen for low energy availability or relative energy deficiency in sport, which is just problematic low energy availability. We're only going to screen for that in bone injuries, but we're seeing that the presence of problematic low energy availability also increases their risk of other musculoskeletal injuries in the runner, tendinopathies in particular. So anytime you're working with the athlete, it's really important to screen for these and to screen for this. And of course, our job as physios is to screen. We don't treat this, and then we need to refer out. So I think that having a good sports medicine physician that you're working with, a registered dietitian who has experience and expertise in working with the endurance athlete, who understands low energy availability, is really, really critical. And so those are 2 people that I end up leaning on a lot. We've got a really good team that I work with here, and also I think other groups too, to work with, as well as like a psychologist, for instance, from a counseling standpoint. An endocrinologist can be very, very helpful as well. So some other things too, and I think Brad hit on some really good ones. Just total volume of exercise per week matters a lot. And so we know there's some really interesting statistics that for every 1 hour that we add over 4 hours of exercise per week, our risk of a bone stress injury goes up by 5%. Now, once you start getting above 12 hours of exercise a week, now we're up to a 4.9 times greater risk of a bone stress injury than if you were just running 4 hours or less a week. Now, 14 hours or 12 hours a week of running sounds like a lot, and it really is. But there's a couple of populations that you're going to see that in. You're going to see running that much in the elite athlete, the ultra runner, which is a group that I work with a lot. So we see that bone stress injury history and incidence is quite high in ultra runners, the triathlete, and because of that, it's the other exercise that the person is doing. And so the athlete who cross trains a lot, and that's one of the things that we run into a lot, is we see athletes who tend to do a lot of cross training. And so we always need to be really, really careful about adding exercise volume or unplanned training volume. And so, for instance, it might be anything that's seemingly as benign as the athlete riding their bike to their team practice. That's exercise. The athlete who maybe walks a little bit further, takes a longer route, or walking their dog more every day, to the athlete who is trying to increase their exercise volume by doing stationary cycling or riding a bike, or one of the things that we have here that's very exercise intensive that you might not have as common in Australia is cross-country skiing. So that's one of the things that is a much more energy intensive exercise than running is, which is already pretty high as it already. And then so if you add that on top of the running that you're doing, that will also increase your risk. And then the other one too is we often, and this is kind of again why it's really important, to your point earlier about zooming out, we often think low bone density, I'm going to prescribe a weightlifting program or a resistance training program, but you have to keep in mind too that you're also increasing the overall exercise load and metabolic costs of that athlete's week. And so what we tend to recommend is for athletes to eliminate at least one of the running sessions if you're going to be doing that. But at a bare minimum is consider consuming more calories. And I think where those calories are coming from matter a lot. So, we need to make sure your bone's very demanding for a high carbohydrate diet. So making sure that you're maintaining this high carb diet. But like another risk factor that we screen for too is GI distress. And you see that too. You see it like we'll take this extreme example of the athlete or the individual with an eating disorder, and you know that for someone who has an eating disorder, we know that GI distress is a major sign of problems there, and that's because it takes a lot of energy to digest our food. And so back that up to someone who is either intentional or unintentional underfueling, who's a runner. We know too that if you see this GI distress, that often means that they're just not consuming enough calories to digest their own food. But the flip side of that too is if you're experiencing GI distress from running, you're not going to consume as much. And we see that a lot at these ultra runners, triathletes, or the elite runner who's running maybe perhaps a couple sessions per day.
That's a fantastic summary. And I'm curious, in terms of if you've suggested to your athlete to perhaps make those modifications to their training program, what sort of timeframes do you use to actually measure if that modification has been significant enough to make some clinical change?
You're talking about like for bone health, you mean?
Correct. Correct.
Yeah,
If you've
yeah, for
noticed
bone
there's a
health. Well,
deficiency issue.
yeah, so what we do, so you think about how long it takes bone to adapt, and so there's some really great studies in the military that look at this. And so Mitch Rao, who's an epidemiologist in San Diego, he's done a lot of work with runners, but also has done a lot of military type work. And so he has this really great paper that was published a couple years ago that looked at strength training and females before they enter basic combat training. And what he found was that if you do heavy strength training for at least 7 months before you go into basic combat training, you have a fourfold lower risk of experiencing a bone stress injury when you're in the military. So those are like really amazing numbers. However, if you do the same strength training and it's less than 7 months, there's no change in your risk of bone stress injury. So that speaks to the fact that there's a delayed response in loading, and it takes your bones a while to get stronger. So that matters. So it needs to probably be at least 7 months, if not longer. And when we're looking at DEXAs for looking at bone density, we know that it's really hard to see clinically meaningful changes on a DEXA, like less than a year. And typically 9 months is going to be, bare minimum when it comes to taking a look at that. There's some really advanced imaging techniques that are done in research that the military also will use. It's, high resolution PQCT, which is of course, there's a lot of radiation anytime you're talking about CT scans, but that can show changes in bone microarchitecture, improvements with loading in as few as 12 weeks. But really, from a DEXA standpoint, you're looking at 9 to 12 months. The other thing too, I'll say too, is the type of exercise you do matters a lot. So I used to be really on board with doing lots of strength training for our athletes who have bone stress injuries, but we've really have kind of pulled back on that quite a bit. We started relying a lot more on plyometrics, and I really like plyometrics a lot because it relies more on your passive energy storing structures, tendons, for instance. And so you're doing some sort of a plyometric type thing. You're storing and releasing energy in these passive structures, meaning passive because they don't take a lot of energy. And that's why when we run, we're so efficient because we're storing and releasing so much energy in our tendons. Muscle, when you're lifting weights, requires a lot of calories. And so, in fact, that's why when you look at weight loss programs, they typically will involve some sort of resistance training. So we tend to just do heavy strength training when we're trying to target the lumbar spine and femoral neck. For lower legs, we tend to do many more plyometrics. And if you had to choose between the two of those, I would probably go with plyometrics because your energy demand is going to be so low.
And what sorts of plyometrics would you be doing, and what sort of dosages would you be prescribing?
Yeah, so we know that the bone loses its sensitivity after about 60 repetitions, the same type of load. So we tend to do like low volume, but high magnitude and high strain rate type of things. What I mean by magnitude is the force is very high. High strain rate means that you're stretching the bone very, very quickly. So from a plyometric standpoint for foot and ankle, like a pogo type hop where you're springing off the ground very, very quickly. So a good rule of thumb is the shorter your contact time, the greater you're focusing those loads on the foot and ankle. The longer your contact time, for instance, if you're cueing someone to land very soft, they're going to bend their knees and their hips more. That's going to put more loads up on the femur. If you're looking to get loads on the femoral neck, it's really important to do unilateral or single leg stance exercises, particularly hopping from side to side. That's going to cause a lot of bending and twisting on the femoral neck. And so we tend to do a lot of like lateral hopping, like off of a step, almost like a lateral skater type motion. And then we like doing like a pogo hop, like over perhaps some low hurdles where they're getting that for their foot and ankle.
That's fantastic. Brad, I know you've got plenty to add on this as well. It's written all over your shirt.
I was actually taking notes, Sarah, but yeah, look, we do have the clinic called Pogo Physio, but it wasn't a direct point to the
plug there.
Point to the like wasn't a direct point to the power of these plyometrics in what Rich just shared. But I think it's a really, really insightful, obviously cutting edge sort of little masterclass Rich has just given us, and it's something that I think working so heavily in triathlon where the overall training hours are so high. And typically as physiotherapists with any of these running related injuries, be it soft tissue, bone or joint, we're going to want to use some exercise therapy intervention that typically will be geared towards the heavier end of the continuum. It's something that I've learned to hopefully be better at as a clinician. And that is to say, look, you've got to fuel for these strength interventions. And so I think what Rich just shared is really, really, really fascinating. So I think that's probably just all I would add there, Sarah, is people underestimate that going and doing a strength intervention requires calories. So fuel around that, those extra hours need to be accounted for, particularly when you're working with the high energy expenders, the elite athletes, the triathletes, etc.
Yeah, if I can just kind of just build on that a little bit too. I think the other group that I'm really careful with is the athlete who's had a disordered eating history or even an eating disorder history. And we know that, of course, most runners are quite fearful of bulking up or adding muscle mass that comes with weightlifting. And so we spend a lot of time doing some education with our athletes. We tell them like one of the easiest ways to reduce the risk or the chances, I don't want to say risk, but because it sounds like it's bad, but the chances that you're going to add perhaps unwanted muscle mass is to keep your volume low but keeping your loads high. And that's the easiest way to keep your volume low is to be lifting heavier weights. And a lot of times people think that lifting heavy weights is going to add more muscle mass. So if you keep your overall volume quite low, and one of the things too that we know is that if you lift high repetitions, particularly if you're using multi-joint exercises, so like I don't know, like a squat plus an overhead press or something like that, the central nervous system fatigue increases. And so it takes the more central nervous system fatigue you experience from those multi-joint exercises, that'll often bleed over into your next workout. And so we make sure too to keep our volume quite low because of that. And we try to avoid like these large multi-joint exercises because the athlete who experiences some fatigue during their next run session that they will trace back to their lifting session will automatically lift less weight the next time they come in. And then for that athlete who has an eating disorder history or a disordered eating history, we're really careful about adding extra some sort of weightlifting in it. From a plyo standpoint, I feel like we can do that without perhaps triggering some disordered eating behaviors or something along those lines. And so again, that's kind of why I always go back. And again, the plyometrics again are very efficient from an energy cost standpoint as well. So the athlete that we start adding heavy lifting with, we tend to do deadlifts and I really like a hex bar squat when it comes to like strengthening the lumbar spine is from a bone standpoint, but also because you're loading those muscles and that's going to be pulling on the bones and that's going to be providing that bone stimulus. We do those with both legs. And so they're lifting with both legs, and that means I can get more weight on their shoulders, more weight on the squat rack. But again, we're really, really careful to who we're going to add that with, and we tend to wait a little bit of time and do some plyometrics first.
Fantastic summaries. I think as physios, we're constantly in this wonderful role where we are the conduits of translating that research for our patients as well. And I think sometimes we sort of don't necessarily share as much of the research as we could and should. And so I think you've both summarized that wonderfully. Um, my last question, we've sort of touched on it with the footwear side of things in the way of technology, but I'm keen on your thoughts as to what the role and the limitations of current technology is in the evaluation of runners with injuries.
Rich, do you want to go first?
I'll let you go. So yeah, you take this one.
I think clinically, Sarah, there's pros and cons. I think, like most things in technological advancements, by and large, runners I feel have more data available, which they do, and so therefore that either I think creates a greater awareness of what they've been doing, some objectivity. Uh, Runners typically overestimate how many hours they train. I think one of your prior research pointings was that,
Mhm.
Rich. Well, they underestimate, what was it? They underestimate how many hours they've trained and overestimate
Mm.
their kilometers.
Yeah, it's super fascinating. It depends on the runner. If it's so just runners typically they tend to overestimate the amount that they run by about 26% if you ask them to tell you what they do. And that's compared with like GPS data. But for athletes who get a bone stress injury, they tend to underreport their overall volume. And
Mm.
so it's not that they're being, deceitful. It's just that I don't think they always recognize how much exercise they're always doing.
Mm.
And so I think, thanks, Rich. I think it gives some objectivity to it. I find it really nice in a clinical setting. Strava's got limitations, but look, you can pull out an athlete's Strava graph and you can get a really quick visual on their running workload if we're talking about running related injuries. So I find that really helpful. I think there is no escaping what one of the well-credentialed triathlon coaches has referenced as Strava Noia. The runner that wants to wants to impress their running peers. I don't think any of us are immune to that. So I think there's real challenges with that. And I was interested just anecdotally to see one of in triathlon, the sport's greats recently announced his retirement, 9 times world champion. And he commented that, he was reflecting on the journey of his career. I think it's 28 years at the professional level, around about that time. And he said, he really bemoaned the onset of GPS watches. He saw them as something that he felt had detracted overall from the running community. And I find that was an interesting anecdotal comment. But I think the point is there's pros and cons. GPS watches are amazing. There's training apps like Training Peaks and things for obviously the triathletes tend to use that a lot. So those things can be nice clinically just to get quick updates. You can even be invited into an athlete's Training Peaks diary. I'm on a few there to help with load management. So there's lots of pros, but there's also the cons,
Mm.
and it's probably what I'd say.
Yeah, we use particularly for our ultra runners and trail runners, we use the vertical gain, or elevation gain from GPS a lot. I find that to be really helpful.
Mm.
Particularly for the athlete with a foot and ankle injury or a knee injury, because of course going uphill, that's going to be bigger load on your plantar flexors. So Achilles tendinopathy patients, we pay really close attention to that. Knee, I mean, of course, the elevation gain, you have to go down too, and that's where
Mm.
those loads are going to be greater. And so, I know sometimes people kind of like are a little dismissive of acute chronic workload ratio calculations. We don't use it for distance, but I find it to be really helpful for the athlete to plug in their elevation gain per week. And then you can really spot often like when the athlete has done this massive spike in the amount of elevation gain because their overall distance might actually be less, I'm saying, or it might actually be less because you're going uphill so much
Mm.
that you're not going to be training as much. And so you can get kind of lost in there. You're like, oh, I don't understand why I got this knee injury. I didn't increase my overall running volume or kilometers per week or what have you. But the amount of elevation gain that they did goes up quite a bit. And so for the athlete to see that, I think can be really really quite helpful. We actually use running watches a lot just during the day for like looking at step counts, and I think that can be great. There's a really nice paper that came out of the hospital for special surgery a couple years ago, and it looked at athletes recovering from a bone stress injury, and it found that the average person recovering from a bone stress injury, you can barely tell that they have the injury if you just look at their step data. They're still hitting about 10,000 steps a day. Some people in the study were hitting as high as 25,000 steps per day. And even though they were on some sort of assistive device or they had a walking boot on. So, and they were even still experiencing pain during, despite this. And so, of course, you're not supposed to be experiencing pain when you're recovering from this injury. So, I think just looking at the step counts can be hugely helpful. But man, I'm with you, Brad. I don't know who's that. Was that Gomez who said that, or was that,
Correct.
or yeah, yeah. And what a star runner he was. I mean, just phenomenal runner. And I saw that he retired, and man, what a great career. Yeah, I would agree with that. And I know a lot of really spectacular runners have kind of moved away from using their GPS watches. And I mean, running really tends to lend itself to using a wearable device or something like that because it's such a repetitive activity. Versus like basketball, it's very hard to track
Mm.
loads playing basketball. And so I think like, well, how do you know it's a hard basketball game? Well, like how tired are you afterward? And I think that might be a better metric for a lot of runners to be using instead of how many miles I ran this week or how much vertical gain. It's one of the things I hear a lot from our trail runners.
That is a fantastic summary. We are in a very data-rich world, aren't we?
I think
Sure.
Sorry, carry on.
Oh, Sarah, I was just thinking that zoomed out response to that question, but the upsides of things like we've all got smartphones or generally iPads, and doing things like basic qualitative gait analysis where we just can get a quick encapsulation of someone moving or looking at their hopping mechanics, slow mo, and we've all got that power of technology available to us clinically, which has apps available to plug in for clinical measurement. So I think overall we're winning with technology, but we've just got to, I think, monitor the dark side, manage the dark side.
We can all tell you exactly how many minutes of deep sleep and whatnot we're getting a night and all of those things. Well, I suspect we could carry on talking for hours on this topic. But before we wrap up, do each of you have a key insight for the clinician listening as a takeaway for today's discussion, or from today's discussion, rather?
Rich, I'll let you go first.
Ooh, yeah, that's a good question. I was hoping to stall a little bit and have Brad go for her. I would say, so I think you said it really well earlier, and that's zoom out. I think like don't get fixated on one risk factor and understand that our biases can really, cause us to look at things really closely, and hone in on one thing. And I think part of that is always like kind of questioning our biases a bit. And it's a really super interesting paper was published in Sports Medicine Journal last week that kind of questioned the relative energy deficiency model. And well, I don't necessarily buy everything that's in the paper, but I think their points are quite good. And that's that a lot of things cause our physiology to act like it's in a low energy state, like such as stress. We know that sex hormones get suppressed. So testosterone, progesterone, estrogen, all those get suppressed when we're in a high stress environment, particularly if it's very long. We also know that happens with sleep as well too. And so I think zooming out a little bit and looking at the athlete as a whole and seeing what's going on in their life, I think that's a really important part, and not always getting so worried about filling out like a screening tool or something like that. I think can be really helpful.
Sarah, I'd probably
Fantastic.
just point towards the psychology of the runner. I think I'm naturally just quite an empathetic clinician, and attached to any running injury is a runner, of course, but that runner has beliefs, has reasons for why running is important to them. And I think one of the key things clinically can be to identify what those reasons are. Sarah, why is it so important to you that you get to the Melbourne Marathon? I've had people tell me, well, it's because we've lost a child through illness, through cancer. It always sticks with me. And now I've got time after that illness to try and improve my health. And so that's why this is important to me. I want to do the marathon to honor my late son, and so there's always a couple of layers down as to why that runner might be conducting their training in a certain way. And I think even just behavioral drivers, such as, I think this is a big area that the research may go in time, is looking at drivers, things like ADHD. So many of I think the running population will be on different spectrums or potentially ASD spectrums. And what influence does that psychologically have on their behavior, their behaviors? Oftentimes the running might be their coping strategy, their only way of getting through the day functionally, and then an injury takes that away. So where does that now position the athlete in terms of well-being? So I think being able to really identify and get around the psychological side of the impact of their injury is probably just a really key thing that I think clinically we don't want to overlook.
Fantastic point. And as you've both said, treat the athletes in those shoes.
Mhm.
Beautiful.
Well, a huge thank you to both of you. This has been a fantastic talk. So thank you for sharing your invaluable insights on managing running related injuries.
Thanks for the invitation, Sarah, and thank you, Rich.
Yeah, thanks. Thanks, Sarah. Thank you, Brad. Thanks to Physio Network. It's been really enjoyable. So thanks for having us. I really enjoyed our conversation today.
No, thank you both so much.